A very good, a very good afternoon to all of you. First of all, I would like to thank the organizers for giving me this opportunity and also to my executive director who let me come here. I also want to thank my teammate Vaishnavi who has made the presentation for me. Last year, I had come to Tamil Nadu, had led the Common Review mission. When we went back, my entire team said that we should go to Tamil Nadu at least once a year to meet the people, gather all the motivation and sincerity and the new things that they are doing so that it lasts through the year and the next year we can again go. So thank you for being one of the best public health systems in India. The topic that has been given to me is new programs, new technology, the new burden that has come, and we will see how it has become a burden, and what should be the workforce management policy and what are the challenges. Now, to talk about this, I will go back this is somewhat a repetition of what Dr. Bhushan has presented, but this is also relevant for this session because the DALIs came down for India as well as for Tamil Nadu. So for India, it was 46%, for Tamil Nadu, this is 37%, but then Tamil Nadu was already at a better place. So that is why the increase is less. If we see the top 10 causes of death, 1990 to 2019, this has also changed. So this is for 1990, and these are for 2019. So much work was done in maternal and child health that it no longer is one of the top 10 causes. Coming to the DALIs, that also has changed, and we all know that NCDs have grown, and then injuries also and mental health disorders. All this is known to you. Life expectancy, Tamil Nadu has done a lot better than India. Now, because our health systems matured, and because we are now moving from disease, somebody told in the morning that from disease-specific programs, we need to be holistic. And so many programs were there before. Now, from selective, we are moving to comprehensive and universal care. So that is what CPHC is about, and universal health care is about. But in doing so, it started raining, almost like the rains in Chennai. And this is on the human resource of ours. And they have to work in this, and they have to keep balancing, and it is very, very tough for them. I think one of the reasons is also that in Tamil Nadu, we want to do our best and be the best always. After interacting with, everybody here, when I take sessions, I tell that in Tamil Nadu, if a kid gets 99%, nobody talks about that 99% at home. They are all after that 1% that he could not get. So I think this also brings a lot of pressure on us. As if that was not enough, the new programs were not enough, we now have new technology. And this is IBM's advertisement, though in practice, there were many issues with this. let us see what are the things which directly affects us. So in digital advances, we can group them into three major user groups. One is, of course, individual. You all know that we all have a lot of wearables now, a lot of implantables are coming, and these help the patients themselves to look after, and also the healthcare providers can use them to look after the patients. The second group is of digital tools which support diagnosis, treatment, and management. And here we have the electronic health records, the hospital information system that the minister was talking about. The third is still evolving, and here there is a lot of scope of doing a lot better work, and this is where the millions of data from the individuals and from the care providers, from the wearables, as well as from hospital information system can be brought together, and you as public health personnel, the experts, if we can go through this data, analyze, plan and prioritize using this data, we can bring a lot of change. Many of the digital initiatives, they depend on mobile internet connectivity. And you can see that how India has progressed over the years. And India has done better, but when we look at this data, we should not forget the users who are still not in the net, who are either out of the coverage gap or they are not using because of some reason. Now, during COVID, most of our healthcare providers used a lot of digital apps, and that is why India is one of the forerunners with 88% of our healthcare providers using some kind of digital technology. At the national level, we have the National Digital Health Mission. Here on this slide, I would like you to focus on the improved clinical effectiveness as well as the reduced administrative burden. So if we have good systems in place, then this will become a reality. But we still find that there is a little bit of resistance among the staff. There are two reasons, main reasons. One is the infrastructure for digital health is not there, and second, the capacity building of the human resources. Also, there is some kind of fear in our human resources that we may be replaced by this digital technology. But that is not true. It is going to help us become more effective. In fact, a research study shows that if we have the digital health implemented properly, then depending on the cadre, about 10 to 48% of the working hours will be lessened. So this is going to be a game changer. Now we saw how the programs have come, we saw how the new technology has come. Let us see what has happened in the human resources in last 2-3 decades. The first thing that has happened is that we have increased the supply of healthcare providers. So a lot of medical colleges, a lot of doctors, a lot of nurses, and other cadres also coming in. Then we have the new cadre of mid-level healthcare providers. And in other states, we have ASHAs per 1,000 population. Here in Tamil Nadu, only in tribal areas we have ASHAs, but we have women health volunteers here in the MTM scheme. I would like to go deeper into this HRH issue and talk about the UHC framework. Availability is not, we cannot equate it to supply. So we have a lot of doctors and a lot of medical colleges, but do we have so many sanctioned positions? Do we have all those people in place? And for that, we need money. So sanction numbers need to go up. The second thing is accessibility. So geographically, in very far distant areas in Tamil Nadu, you have done well because of your policies. But when I see nationwide, we have not been so lucky. We have not seen large scale success in getting people, in getting the doctors in far off distant places. The third aspect is of acceptability. Now, when we talk about acceptability, we generally talk about socio-cultural uh, factors and also gender. One thing that we have been observing across many states is that our primary healthcare teams, they have become women-led and mostly women. So we have the VHNs who are women. Then the MLHP is because most of them are nurses, they are women. Our ASHAs are women, and then we have women health volunteers. So are we losing out on our male population? Because even for NCD screening, we saw in the field that we are not able to capture all. So is there anything that we need to do about this? Again, service utilization. Generally, when we talk about service utilization or productivity, we think about, why a person is not working more. This is not about this. It is about what are the things that we need to do to make our HRH more productive. What are the other things that we should give? Is there a problem with equipment? Is the facility far off and people are not able to reach? Is the facility well made? Do they have all kinds of provisions? So service utilization and monitoring of service utilization is particularly important to enable our healthcare providers do better. And finally, quality. With mushrooming of private institutions, we need to keep an eye on the kind of people who are coming, their skills, but quality also in terms of how the patients perceive. And the behavioral aspects also come in here. HR has to be made a priority. Now, this seems like an oft repeated quote. Everybody would come here and say, human resources is the most important thing. I sit in many of the committees and many meetings. We talk about finance all the time. We talk about strategies. Hours go into the meetings where we are discussing the strategy. How much time do we spend on human resources? And when we talk about human resource, generally it is about vacancies and training, nothing more than that. If we really want to bring any change in human resource, we need to understand what constitutes our human resource, the individual. So do we know enough about the individual? The background, what kind of treatment we give to the human resource, to the individual. Maya Angelou had said, if you get, give. But if I do not receive good treatment, how would I give good treatment? Then the individual is not alone. He or she comes with the family. What are we doing about them? So from national level, we have just started having conversation about reserving seats in the best of the schools for those who are working in far off areas. So if it can be done for the armed forces, can we think of doing similar thing for our healthcare providers also? Then it comes to the team. We are put in a team and not asked how you are faring. So if I cannot gel well in a team, is there any recourse? Would I be able to join some other team where my competency would be utilized better? What about the working tools and environment? When we go to the field, even now in India, I find that some of our health and wellness centers, they are made of tin or asbestos. And in the summer times, the MLHP is not able to sit the entire day. So something like an AC, which used to be, perhaps a comfort equipment, it has become a necessity now. But we are not thinking in those terms yet. Coming to the organization and sector, I have a feeling that we have a little bit of ostrich syndrome here, that the entire world is moving towards the gig economy. People are changing their professions mid-course. Many people are deciding to, go from health to some other sector, engineers coming to health in big numbers. And we are still thinking of people would come to our health sector and serve for 30, 35 years. So maybe 60, 70% of the people want that. It might not be true for all. And especially when the world is volatile, uncertain, ambiguous, and complex. In this, it is very difficult for people to work for 30, 35 years in the same kind of environment. And what happens when there is stress or danger? People either fight or flight. The new thing that we are hearing now is FIRE, financial independence, and retire early. So all this is coming, but in health, we are still stuck in age-old HR traditions, which is basically personnel and administration and a little bit of training. We have to move from there to human resource development. Now, bringing all the 4 things together, new programs, new technology, HR, and the VUCA world. What do we need to do? We need to pivot. Evidence-based policies and person-centeredness is the call of the day. New programs we have to analyze. Are they actually new? Rabies vaccine. Weren't you giving them earlier? Snake bites. Wasn't our system treating them? But we now have a program for each of them. Aren't we providing services to the same people, almost the community, the people, the population? They're all same, right? There are new things, new challenges coming in. Climate change is definitely one of them. But we also need to analyze, do we need to drop a few things? Because many of the things that we started in government, it is very difficult to drop. In recent plan meeting, one of the states told us that they still have a few posts of lantern cleaners from British era. And it's still continuing. Maybe only 1 or 2 people are there. But do we do this kind of check? What are the things that we need to drop? Also, I think we are in the overlap period. The digital has come, but the manual has continued. When we go in the field, we see that on mobile, our VHNs are working. They also have, some people have laptops, others have tablets, but they also have 29 registers to fill. So we have to see to it that this period of overlap is minimized to the extent possible. But if we can do this, minimize the overlap and bring in good digital technology, then perhaps once it becomes user-friendly, our HRH workload will come down. This is my final slide, and here I would like to talk about what we are doing now and what are the things that we need to do in future. So we still think about filling up of vacancies. We have to move towards finding the best fit. Find the competencies, skills, and proven knowledge. We are put in a team. Can we think of forming a team? There is a buddy-buddy scheme where an EMOC and an LSAS provider comes together and go to a facility to serve. Currently, the government chooses them. They select. Can we leave it to the service provider? You select your partner and you go and work together. Can we do this? We are thinking about individuals' competencies and performance. Can we think in terms of teams' competencies and performance? Because in the field, it is the team that matters. We are working together, not alone. We have prescribed in-service training programs. Can we move from there and give choices to people? And could there be a better mentoring? Not only training, but mentoring. From single specialization and vertical approach, can we move towards multi-specialty and multidisciplinary, both at individual levels and team levels? And here, I think by multi-specialty, I also mean doctors and nurses who would also have specialization in digital technology. One of the reasons we are not able to make our digital technology user-friendly is that we do not have service providers who have in-depth technology knowledge. Once we have many people like them, then it will definitely become very user-friendly. And lastly, we want to go from maximization to optimization. We are going after maximization. Lot of colleges, lot of students, lot of doctors. But what is the optimum? The minister had put it very nicely in his speech. Tamil Nadu has given us many things, but I think HRH still needs more focus. All the leaders everywhere, across the sectors, they have prioritized talent. Once you have the talent in place, once you have the HR in place, your strategies would come by itself. And then the implementation becomes a cakewalk. Now, Tamil Nadu has given many new things, the TNMSC, MTM scheme, your women health volunteers, Pick Me app, and I can count many more. I think HR is the most difficult area, a very hard nut to crack. And if it can be cracked, I think Tamil Nadu is the place where it can happen. You please walk, and I think once you make the path, we are sure that other states will follow you. And we are looking forward to the day when Tamil Nadu does this. Thank you so much.
Thank you, ma'am. Thank you for trusting us and the public health system in the state of Tamil Nadu. And also focus on the selective to comprehensive primary health care, explaining the barriers for adaptation of digital technology for health and the way forward. And I really like the comment, if you get, give, and how can I give if I don't get? And facilitating the focus on the needs for healthcare providers and from maximization to optimization. Thanks for all your thoughts. And we request
on behalf of our department, I request our Additional Director of Public Health and Preventive Medicine, Dr. Somasundaram, to come on stage and felicitate the speaker, Dr. Mona Gupta.
இந்த பக்கம்